Hello, my name is Jacqueline Tamis-Holland, and I'm an interventional cardiologist at the Cleveland Clinic.
Hi, I'm Venu Menon. I'm Director of the Cardiac Intensive Care Unit and the Cardiovascular Fellowship Program at the Cleveland Clinic.
Unfortunately, out-of-hospital cardiac arrest is not uncommon, occurring in about 350,000 patients each year, and it's a devastating condition in which fewer than 10% survive. The purpose of our document is so we can discuss in more detail and highlight the role of the cardiac cath lab in the management of these patients, because the cardiac cath lab is a critical link in the management. So we start by talking about the assessment of the patient, and I think that's incredibly key. It's a time-sensitive situation, but you want to be sure you've done a thorough assessment and try to understand what the reason for the arrest is and how best you can help the patient and whether there's a role for the cath lab to help this patient further. And as part of the assessment, I think, we really emphasize throughout the document the importance of individualized care. There's many risk factors in assessing somebody with a cardiac arrest, many signs that tell us the potential likelihood for a good outcome. And we really want to individualize care, look at all of the possible factors, and look at the potential risk scores, and then together put everything together to decide how best to treat our patients.
Now, one of the things that we always struggle with in cardiac arrest has been the neurological devastation that often accompanies these patients. And that's been the constant struggle where we know the benefits of opening up the artery, but those benefits are often not realized because of the hypoxic anoxic encephalopathy that comes up. Does this document really help the clinician in some way think through that situation in an acute emergency?
Yeah, we provide an algorithm and we provide some information about the features that indicate a poor prognosis. But what we really want to do is we really want the clinician to assess the patient in detail, assess them for all of the factors that would indicate potentially a good or a poor outcome, and then really individualize care. We don't give an absolute cutoff or an absolute number to say stop or don't. It's really a matter of every individual patient. So we have this nice figure that, in my opinion, shows you the spectrum of risk. We start with, how was it a witnessed arrest? How long was the patient down before CPR was initiated? Was CPR very good CPR, or was it inadequate from somebody who didn't know how to do it? Was this somebody when they arrive? What is their pH? What is their lactic acid? How old are they? Do they have other comorbidities? And so together, these are all the things we want to think about. And there's really not sort of a set cutoff to say this is futile or this is definitely going to have a great outcome. But together, we want you to individualize care.